Okay, good afternoon, everybody. You're very welcome to this afternoon's All Ireland Social Work Research Collective Seminar, and we're delighted to be hosting this in conjunction with the Five Nations Research Collective. Just to introduce ourselves a little bit, this is a collective and a network that has been established, I suppose, back in 2019, initially when we had our first All Ireland Social Work Research Conference, and I suppose our practitioner research a support mechanism really has grown legs in terms of our Five Nations Social Work Research Collective, which is compiled of Dr. Niamh Flanagan from Maynooth University, Ivan Brady from Trinity College Dublin, Kerry Cuskelly, Senior Principal Mental Health Social Worker, Lisa Morris, Dr. Lisa Morris from the UK, Dr. Wahida Kent from Wales, and Dr. Amanda Critchley from Scotland. And really, I suppose, the purpose and intention of, I suppose, our collective, but also today's seminar is really to provide a platform and a mechanism for social work practitioners in the field to showcase and share and disseminate the research that they're carrying out as part of their work. Again, for ourselves as social workers, it's so important, and we're increasingly being asked to evidence and provide an evidence base for the work that we do. Yet we know that often it's very difficult for us as for practitioners in the field to find time to carry out that research, and indeed to have the necessary supports or funding and assistance to do that. And really, I suppose this network and this initiative is really an attempt to try and support and better support social work practitioners in the field to carry out research. So we don't have a lot of time today. So in the interest of time and progressing things, we'll probably get started in a few moments. Our first speaker is Elaine Donnelly, who I'll introduce to you in a moment. But what we would like to do at some stage is to take a screenshot of all participants, again, to try and capture the seminar. So my good colleague Niamh is going to take a screenshot at one stage. Perhaps we'll do it at the question and answer session after Elaine's presentation. So we might ask you or kindly request you to turn on your cameras so we can do that. So without further ado, I'm going to introduce Elaine, and today's session will start off with Elaine's presentation, followed by questions and answers, and then we'll move into Phil Butler's presentation. So I'm just going to introduce Elaine, and Elaine, if you can get ready to share your screen, and I'll read your bio. So Elaine's presentation today is called From Practice Concern to Research Idea, a case example of a practice-based qualitative study in mental health services. Elaine is a social work team leader currently based in the High Support Mental Health Unit. Elaine has 13 years of experience practicing in mental health services and migrant support services. Elaine completed a Master's in Applied Social Research with the Trinity College Dublin School of Social Work and Social Policy in 2018, for which she undertook research on the topic of multidisciplinary teams' understanding of domestic violence in a mental health setting. Elaine is a member of the Irish Association of Social Workers Special Interest Group for Adult Mental Health and the current IASW representative for the HSE Health and Social Care Professionals Research Subgroup. So without further ado, I'll hand you over to Elaine's very capable hands.
Great, thank you, Sarah, for that lovely introduction. The bio always seems longer when you read it out. I'm sharing there, I think that's okay, yeah. So sorry, bear with me for 1 minute and I'll get going. So yeah, thank you for that introduction, and I'm delighted to be here today to talk about a practice-based research study I undertook as part of the Applied Social Research Masters I did in 2017 and 2018. So I'm a social work team leader here in St. Patrick's Hospital, and I'm based in the special care unit. And today I'm going to be talking a little bit about my experience of conducting this research, less so about the findings, but just some of the challenges and insights and opportunities that I gained from doing this research, in the hope that people might be a little bit interested and inspired in taking on some research themselves. Before I talk a little bit about the study itself, I might just explain how I came to research research, because I wouldn't be that comfortable with the identity as a practitioner researcher, and I think probably that's not unfamiliar within social work. So I did the BSS in Trinity in 2009, and at that time there wasn't a dissertation or a research study as part of the course qualifications. So when I entered practice, I had really limited research experience. And I was working primarily in mental health services, which I found to be really dominated by discussions about research, but mostly medical research like quantitative methods or CTs. And I noticed as I continued in my experience that certain kinds of knowledge are seen of particular value. And absolutely there's a hierarchy of evidence, but I often seen that that was at the expense of really important rich data that maybe social work in particular could contribute to. So I returned to do the Applied Social Research Masters in 2017, and I conducted a research project under the supervision of the inimitable Dr. Stephanie Holt in 2018. So basically, I suppose I wanted to talk a little bit about how this started for me, not aside from doing the Applied Social Research Masters, but really this topic was an area of concern for me within my practice. I would have particular interest in women's mental health and improving responses to gender-based violence. And I would have seen in my practice experiences a lot of, difficult responses, a lot of gaps in terms of how service users were responded to around this area. And I had a growing concern about this issue. And that kind of lines up with what the international research would tell you about DVA in mental health services, that despite its high prevalence and much higher than lots of other healthcare settings, it's widely underdetected in mental health settings. So it's about a third is detected. That inquiry about abuse among clinicians is really low, despite the fact that victims want to be asked, and that perpetrators are often overlooked or undetected. And in recent years, there's been lots of change in legislative and policy arenas in this area, but yet prevalence rates have remained relatively stable. So there's a lot of work for us to do. And what I would have seen in practice was that these issues were marginalised, and I had growing concerns about how service users were supported. I also had a growing sense from doing the Applied Social Research Masters about the unique value of our professional knowledge base and our skills, and how well positioned we are to take on these kind of projects. So I had a bit of confidence from that. But I was also really overwhelmed, because this is like an area of real complexity. And like any kind of issues in social work, there's lots of branches, there's lots of systemic factors influencing how service responses. And, it was hard to know where to start and how to go about it. And so how did I do that? So step by step, really, bit by bit. I started focusing in on, and this is a standard diagram for how you would conduct a research study, but I started focusing in on what exactly I wanted to know, because initially I was thinking about doing something like a survey and establishing professional knowledge and opinions, but I realized that wasn't really going to get to the heart of what I wanted to know. So I had to kind of narrow down that research question through doing a broader literature review, and let the design kind of emerge from that, as I gathered more of a complex picture of what the issues were, what kind of was particularly drawing me to the topic. And then from there kind of led on to the selection criteria of who's in and who's out, and how to do the recruitment and how to do the sampling, and those kind of things fell into place as I went along. That sounds like it was very easy. It wasn't, but that's just how it proceeded, and that was the kind of process I followed. So I suppose from doing the literature review, I understood, I suppose, that what I really wanted to know is how Irish mental health professionals understand and experience this issue in practice. So it was really about understanding and perception and attitudes, perceptions of service gaps, practitioner needs, prevalence and relevance of domestic violence in mental health settings, and just their overall experience of it. So on that basis, I went with a qualitative design, because really that's what helps us to get the unknown processes and understand how, these things happen at a local level, and understand the why and the how, not so much the what, and making comparisons, etc. So what that led me to is the design, which was a qualitative exploratory approach, and I did data collection through semi-structured focus group. I did 6 focus groups with different mental health disciplines, and so I'll show you the diagram of that now in a moment. but I analysed then the data with thematic analysis. So how I started it was really, I had hoped to interview MDTs together. And when I went through the ethics process, I got lots of advice around how that might influence the data I would collect. So there was a strong opinion and recommendations that I would interview disciplines as groups rather than MDT together. So my initial idea was that I'd get MDTs together to get a real life picture of how they shaped the issue, how they talked about it, how they understood it. But in reality, when I thought about it, I got, you know, what would happen was there'd be power dynamics there. And like, as anyone who works in an MDT will know that those issues play out and they influence what people feel comfortable saying, what people hold back on, and that will inevitably influence the data. So I got some really good advice on that from the ethics committee and my supervisor. So my own allocated MDT was excluded from the study, but I invited all basically MDT members that I wasn't working with or had any direct connection to be invited in the study. So I did that via email, gave a participant information sheet and gave them 2 weeks to decide if they wanted to join. So I also had, so they were semi-structured. So I had developed an interview schedule based on a literature review, which kind of covered the main areas that were popping up in the literature review, and that's things that I was really concerned about in terms of processes of response. So this was the sample breakdown. So we had all the core MDT members as per the MHC, so nurses, consultant psychiatrists, junior doctors, psychologists, OTs, and social work. And that really worked way better than interviewing as MDTs. I'm not, like, obviously I don't know that for sure because I didn't do both of them, but certainly it allowed for lots of discussion and lots of interesting debate. And I might just mention, I suppose, some of the focus group pros and cons from my perspective. I think I would not have got the data I got if I hadn't done focus groups, if I had done individual interviews. I think there's an evasiveness that can be present in individual interviews that you might not always kind of get the collective context of how these issues are dealt with. So there was definitely a synergistic quality to the focus groups. There's lots of disagreements, lots of conflict. And I think as a social worker, I was uniquely placed to try and moderate and facilitate those discussions. But then again, it was really difficult to schedule the groups. There was a huge amount of data to analyse, and there was inevitably going to be power dynamics and some social conformity that was present. And that's kind of, that makes up a lot of the criticism of focus group research as a method. But I just included some quotes there of one focus group interaction, which I thought was really nice discussion among a professional discipline group, where they were saying, you know, talking about domestic violence and talking about how their responses were so fear-based. And, you know, what do? We actually don't go down that road. And sometimes that's at the expense of believing a person and actually working with them. So that was just a really nice element to the focus group, and understanding, you know, and seeing and observing that firsthand, how people experience this issue in practice. Just to mention about the data analysis, so the overall aim was to get an understanding of the core emergent teams through thematic analysis, and there are the different phases that we went through. I went through. So I'll talk just a little bit about the main findings, I suppose, and I'm conscious that that wasn't the intention of today's presentation, but just might be interesting to discuss them for the moment. So what I found through the 6 focus groups was, and what emerged from the data was that absolutely people recognise that the service user population was much more vulnerable to domestic violence, and the increased prevalence of this issue was generally reported and acknowledged. There wasn't kind of any debate around that. The debate began really around its relevance to mental health services, because that was really described as unclear. And from that, I suppose, the understanding of the issue was reportedly poor and variable. And it was acknowledged widely that this issue wasn't routinely identified, and that responses were limited, uninformed, and inconsistent. So within, I suppose, the reported knowledge gaps and lack of training that many disciplines reported, social workers were considered the best place to respond. And that really came out strong from the data that social work took a key lead on this. Fundamentally, what came from the data was the role of how this issue was constructed in this setting. So how domestic violence was seen and the lens through which it was seen really fundamentally influenced how it was responded to, how it was seen or not seen, and then how ultimately that shaped practice. So DV was often seen through two lenses, one of mental illness and one of physical violence only. So what that meant was really lots of things were hidden in plain sight and marginalised, maybe if they weren't as clear cut. And that was often influenced by several factors. So for example, training and education, there was a lot of fear and discomfort, and there was the lack of pathways and interagency collaboration. All of those factors seem to support a disconnected construction of domestic violence in the setting. And then that ultimately led to it not being identified and not being responded to. And if it was responded to, it was responded to under the umbrella remit of mandated reporting obligations and risk-averse practices. So really, it shaped the invisibility of DV in this practice setting, and DV was then marginalised from the care plan due to its construction as a social problem, with the resultant patient needs not considered the remit of mental health services. And that's reflected in lots of research that's been done with service users, victims of domestic violence, where they say that when they enter mental health services, it's the first connection to be lost, which seems so bizarre to anybody outside the service, and it seems such a well-established connection, it's hard to believe, but this is what the research is telling us across the board. And that this disconnected construction is influenced again by those several factors, the medical model becoming a really dominant force in that construction. And I've just included some quotes there around, that are reflective of this analysis. In my experience, it's shipped off to social work and it's like, deal with it and deal with it quickly because we need to get back to the main stuff. And it's not part of the primary part of the care plan. It's not a primary concern. So it gets pushed to the side, and if the relevant person isn't there pushing it, i.e. the social worker, it's not given the attention it deserves. So really what that meant was that the responses were really patchy. And it was a risk management issue when it was identified, as opposed to a clinical need. So as opposed to it having any kind of implications for the person's mental health, well-being or recovery. And it often meant as well that it was reframed as marital disharmony. I heard a lot of there's two of them in it and we're not detectives really, how are we supposed to know? Which often led to recommendations of couples counselling where there could be very severe risk issues at play. And that joint meetings were often undertaken with family members in really unsafe ways. Ultimately, as well, from the data, and when myself and Stephanie were going through the findings and going through the data, what was really clear throughout it was the voice of the service user was missing at every step of the way, at every point in the discussion. What was considered a perception for them in terms of their primary needs was not discussed, and the findings indicated that really individual mental health needs are defined and constructed by professionals for service users, and their involvement in that is really limited. Obviously that's a professional perspective, but if that's what's being reported in by professionals, you would wonder, and it begs the question about how service users experience that. So there was absolutely lots of ethical considerations to this project that we had to consider and had to tease out. So there's definitely power dynamics in a focus group, and we could see that play out much less so, I would imagine, than in the MDT format. But within discipline groups, there was obviously differences in seniority, differences in experience that we had to kind of cater for, and individuals were offered a follow-up interview if they wanted it, were offered supports on domestic violence, and were offered that by myself if they needed it. That we have to cater for the fact that it was a sensitive topic and that I was an insider researcher. So I'll just talk now for a few minutes about that. So this has been recognised across the board as a potential ethical implication, and that the pre-existing relationships can motivate how people engage in a study, and due to peer obligation, and that can infer some power imbalances. So what I had to do was really carefully select the participants. I had to make sure that anybody that I would have worked with or had pre-existing relationships were excluded from the study. I had to stress it in the participant information leaflet that the study was voluntary, and that I had to address it at the beginning of the session, that my dual role as a social worker within the service was acknowledged, and that participants, you know, were fully aware of that. I would say fairly confidently that it didn't impact on the data whatsoever, in that I had to play a strong poker face game, in that people had no problem speaking their mind about social work and speaking their mind about service responses and their opinions about this issue. And you know, there was often people very blatantly speaking about social work in terms of the pros and cons to our involvement. So it didn't seem to impact on people's ability to talk up and speak up. So you see there, the social worker would mention it and I'd kind of look at her a bit perplexed and say, good luck with that. So that was somebody talking about their response and how they would normally see domestic violence in practice. And that for a lot of people, once the referral is made, that's it. We don't want to hear about it anymore. That I cut that section out of the quote, you can't see that, but so that was kind of a major consideration for me in doing this research. But I would say it definitely gave me greater insights, because it allowed me, you know, it allowed participants not to have to explain the processes and systems that we were involved in, and they could go straight to the issue. And then I think I was more comfortable and more familiar about what would happen next. And so I was assisted in terms of, you know, interviewing and asking the questions, knowing when to step back and knowing when to use myself, all of those social work skills that we all have, which came into play big time when I was doing this research. And I definitely think it gave me much greater insights, and that there was huge amount of conflict, huge amount of disagreements, and people were very open about their opinions on this issue. It definitely brought up a lot of passionate discussion, as you'll see here from one of the quotes. And this was really centered around how people discuss the issue, as that became a key. So the rhetoric that people used around domestic violence, and how people actively avoided naming it. And this was a discussion between two professionals. They were having a row about how to respond and whether to name it or not name it. And somebody saying, I don't know why we're not naming it, or pussyfooting around it for fear of maybe wanting corroborating evidence. And the other person saying, well, I wouldn't name it. I'd talk to the husband. I'd get more information. So there was a lot of real great insights that came from being an insider research and using focus groups as a method. I'll just talk maybe to some of the limitations of the study. So obviously it was a small study, it was only 27, and so it's not expected to be generalizable, and that also the acute site of the setting of the research site might have impacted on people's priorities. But that ultimately further research needs to come from a service user perspective, because we really need to guard against professional dominance of the recommendations, and we need to be careful not to replicate the dynamics that are already existing there. In terms of my supports, I had really great support from my organisation, and I suppose that's something we really need to consider as a professional, how we build on that, because if we don't have support, we can't do this, and it's really key to how we develop as a profession. So I had taken a day a week off work to do my master's, and I had access to supervisory staff. I had really supportive colleagues. The participants were so willing. I got so much offers. I had to cap it at a certain number, but I had lots of offers for people to attend. And then I could use the paper in my workplace and stuff like that so I didn't need additional funding. I'll talk about just for another minute about the challenges, and then I'll finish up. So just time management, it was probably the most stressful 2 years I've had in a long time. It was very difficult to manage time, but so worth it at the same time. Managing the insider research dynamics was tricky at times, but I think as a social worker, I was kind of well placed to do that. That in terms of the administrative burden, it was quite a lot around ethics applications, but really fruitful in terms of the recommendations I was given. And that it would have been great to have some funding to do the data analysis, but that was very challenging and time consuming. But not to end on a downer, there's been a huge amount of opportunities that have come from this, and that I have done up myself and Steph published an article on the study, which is available if anybody wants it. I'm happy to send on a copy, and that I've had an opportunity to present the research to lots of different groups and make lots of new connections. We've developed a whole policy and service, e-learning training, information document, all based on this research. So there's been lots of good that's come of it. And I think from a social work perspective, I think we're really well placed to do this research. So I'm really looking forward to more of these kind of forums and more support for professionals in practice to do research. So that's me. Thank you all for listening.
Okay, thank you very much, Elaine, for a fantastic, thought-provoking, really thorough presentation where we got a really good sense both of what you did and how you went about it, but also some of those challenges that you had, I suppose, around carrying out your research as an insider. And I suppose for me, it was really striking that whole, I suppose, some of your reflections and findings around conceptualization of domestic violence within mental health services, and I suppose really, some of the ethical challenges maybe that threw up for you as a social worker as well. So really, really useful, and please don't minimize your publication. That's fantastic. And like we will make sure and share that with participants after the seminar today as well. And Yvonne has put a link to your abstract in the chat. So look, we still have about 5 minutes for questions. So does anybody, any attendees, want to unmute and ask a question or have a think about one? I suppose one thing I was wondering, and Yvonne was wondering about as well, Elaine, was actually your recruitment process, because you talked about you got a fantastic sample size in terms of your 27 participants, but did that take much longer than you anticipated, or how did that recruitment piece work out for you?
The recruitment piece actually didn't take that long. So I had so as an insider, I had access to all the contact details I needed, the different disciplines and who I would write to. So I wrote them as discipline groups and I catered it through their professional group. So I did say, for the medical staff, I said the challenges of recruiting medical staff as well acknowledged. I would really greatly appreciate if you would participate, and I got loads of response from that. It was actually just the scheduling which was really difficult. So trying to get everybody in the room at the one time was probably
people's schedules.
Yeah.
And related to that, I suppose I was really wondering, because it was one thing that I really grappled with when I was doing some of the research I've carried out around care planning meetings, and we used focus groups, is whether you used discipline-specific focus groups or just generic ones, because I suppose there's always that kind of concern that people maybe won't talk freely with their MDT colleagues. Or how did that piece play out for you in your research?
Well, that was kind of some of the recommendations from the ethics committee, because I was initially trying to interview people as within an MDT setting. So yeah. I then stuck with, social workers, OTs, everybody just in discipline groups, and that worked out so much better, I think, because there was a lot of indiscipline.
Yeah, we're a little bit cautious, I suppose, of speaking freely amongst some of our HSCP colleagues, perhaps.
Yeah. Oh no, yeah, there was definitely, that was a factor, and people named that in the group, so they were kind of happy enough to relax into their professional identity and get going. Yeah.
And in terms of that insider piece, because again, you spoke to that really nicely in terms of some of the challenges around that, but do you think that maybe helped with some of, I suppose, people maybe being more open, or in terms of the information that they shared in the focus groups, or any kind of reflections on that?
I think so. I think probably my insider knowledge allowed me to ask questions that maybe elicited more data, but I also knew when to step back as well, and to kind of let the discussion flow, which I think that did really help. And people were maybe a bit more comfortable with that it was somebody, some of the stuff that was said was really shocking. Like you said, there was some ethical challenges there. But that didn't seem to stop people in terms of my insider knowing that I was a social worker within the service. Yeah.
Yeah, which is reassuring. They very much take confidence in you. And I suppose one thing I suppose I'm always really, I suppose, keen and passionate about is, you know, where do you go from here in terms of your research? So like you talked about some of the, I suppose, problems you had or some of the issues that the findings threw up in terms of how domestic violence is conceptualized, particularly within that medical setting. Has there been any changes to practice or how you work subsequent to the research as a result of carrying out the study?
Yeah, well, I've been able to do up a policy and responding to domestic violence and make sure that it was seen as a clinical care plan need rather than a risk management issue. And
Brilliant.
currently looking at establishing local pathways between domestic violence services and mental health with Safe Ireland. So there's lots of work kind of that's leading on from that. That might be another research study in the making.
So this is really just the start of your research journey in many ways.
Oh yeah, I'm definitely a baby on the research front, so I've much more to learn and much more to do, I think.
Okay, we have one question just before we move on to Phil from James Halpenny. So he's asked, Elaine, you mentioned at the beginning, but not in the challenges at the end of your presentation, just wondering how you found the dynamics you experienced at work with social work-led research. As my experience is, it's generally medically led. Did you find that you were supported by your colleagues from other disciplines, or were they ambivalent? Or I suppose, what was your experience? And that's a really good question. And something I always wonder about, like, how receptive are people to social work-led research?
Yeah, now, like, thanks, James. That's a really interesting question. And I think like 100% this setting is very focused and dominated on medical led research, and there's lots of funding, and I think other disciplines have much better resources and frameworks and supports to do that. But in my experience, actually, it was people were really receptive to it, and I did get a lot of support, and as I said, I got a lot of willing participants. Not so much with the findings, I have to say.
Okay, people weren't as open to receiving them openly.
No, there was a lot of, you know, requests for things to be sanitized, and, you know, there's a lot of kind of shocking quotes, I suppose, and people all that comfortable receiving that back. But I think in the initial process, once, you know, people were very receptive.
Okay, look, that's Elaine. I think we'd all like to stay and kind of quiz you a little bit more, but in the interest of time, we're going to move on. But again, look, thank you so much. And again, to encourage participants to tweet as we go through the presentation. And Elaine, thank you very much. And we'll make that available to attendees after today. So we're now going to move on to our second presenter, who is Phil Butler, who is a senior social worker in the National Rehabilitation Hospital, Donnelly, and a PhD candidate in University College Dublin. Phil's presentation is entitled Supporting Child Relatives of Adults with Acquired Brain Injury, a resource for rehabilitation teams, a practitioner research project. Phil has worked as a senior social worker in the NRH since 2013, having spent several years prior to that as a medical social worker in acute hospitals. Her role in the NRH involves working with adults with acquired brain injuries, providing emotional and practical support, as well as assisting with discharge planning. And for her sins, she's also the safeguarding officer in the NRH, working with staff and patients to ensure safety and rights of all patients within the hospital. Phil is also currently undertaking a PhD in UCD, and her research is focused on the mothers with acquired brain injury, really looking at the lived experience of mothers and their families using an action research approach. Phil has always had an interest in research, having started her career as a researcher before going into social work, and has been involved in a number of projects in the NRH. And she hopes to continue to have opportunities to engage in practitioner research like this. So Phil, I will hand over to your very capable hands, and really looking forward to hearing this as well. So best of luck.
Thanks a million, Sarah. Thank you for that. I think I'm sharing screen, so that should be okay. So yeah, thanks very much, and thanks very much for that talk, Elaine, as well. It was really, really interesting, and I think my talk is probably similar in terms of looking at challenges and looking at what's involved, but I think
Phil, we've lost your sound for some reason. Have you muted by accident?
Can you hear me?
We can hear you now.
Oh, sorry. I've got headphones on, so they're a bit funny sometimes.
Apologies.
Okay, so thanks, sorry for that. Okay, so yes, I'll just start and just introduce myself again, as Sarah did. Thanks very much. I'm a senior social worker in the National Rehabilitation Hospital, and I suppose I'm working with adults with acquired brain injuries. That's my main role. And I suppose just today I want to talk about a project that I worked on. It's a couple of years ago at this stage, some ongoing work that I'm doing now at the minute as well. So I just want to give a little bit of background to the project, and I suppose look at the aims and objectives and methodology I used. And I suppose more importantly, I suppose for this session is to look at the challenges of trying to do research while working as a social worker, and how I found that. So firstly, I suppose just to say, in terms of just a bit of background, working in the National Rehab Hospital in the NRH, there is, I suppose, and I'm fortunate that there is a culture of research in the NRH, and there's a lot of support for staff who do masters and other further education and engage in research. So that's quite helpful to have that background, and I think it makes a difference. And as Sarah said, I'm also doing a PhD. So I'm getting, good support in that as well. So that's made a big difference. But also, I suppose, how this project came about, sometimes in the NRH, there's opportunities to apply for research grants. So you can apply for funding to work on a project. So for this project that I'm going to talk about today, I was fortunate, I was awarded funding. So that allowed me to focus on the research solely for a couple of months. The funding actually went to paying for my locum, so that I was able to do the research. So I had no caseload. So just to say that was really invaluable, and I think it made a big difference to completing the project, really. The other thing just to say though is, while I say there's lots of opportunities to engage in research in the NRH, really it's been other professionals that are doing it and not social work. I suppose there's a small number of social workers who are interested in research. And recently the social work department undertook a study with UCD on the experience of family meetings in rehab settings. And I think that really sort of highlighted, I suppose, the importance and the contribution that social workers have to research, because we have a unique perspective and awareness of issues that impact service users and families. So if we can, I suppose, give some time to research, I think we have a lot to contribute, really. But it is vital to be given the time to do it, and trying to fit it in with demanding caseload is very tricky. And I think that's probably why there's not as much social work research. So just a little background to the project, so the study that I did. So as I said, I'm working on the brain injury program, and in the NRH in that program, there's an interdisciplinary team working with patients, and they're working towards goals to help people improve their quality of life. And I suppose in recent years, there's an increased emphasis on family-focused rehabilitation. And that's, I suppose, because research shows that rehabilitation outcomes are better for patients when the families are involved. So I think it's important to acknowledge that not just working with the patients, and patients are part of a family system, and we need to include everybody. But I think in the main, what we were seeing was mostly family members that were included in the rehab program were the adult family members, so the carers, partners, and other adult relatives. So there wasn't a lot of work done with children, and it was kind of dependent on different therapists and different social workers who felt comfortable working with children, or felt that there was a need to include them. So it wasn't consistent. And I think that was one of the main reasons that I wanted to do this project, to try and have a more consistent approach to including child relatives. Because again, a lot of the research and literature would say that the impact on children, obviously, when a parent has a disability or an acquired disability like a brain injury, is huge, and it can impact the whole family. And many of the NRH patients will be parents. So for example, we'd have parents who are a mother or father who has young children that they mightn't remember, or they mightn't be able to speak or communicate with them. They might be able to, bring them to school, help them with their homework, all the general kind of parenting tasks that we do. So it's very important for these patients. That's a big part of their identity that I think we should work on. And I suppose the other thing just to say is what I always also wanted, why I wanted to do this. When I wanted to do this research, I really wanted to do something that had a practical application, and that would lead to, I suppose, an intervention or some kind of quality improvement to the service. I've included a couple of quotes on this slide, and these are mainly from some of the social workers would have done direct work with children. And I suppose some of these would show, I suppose, for example, the 5-year-old boy there that worries that his mother had a stroke because his brother slept in her bed and had his leg pushed against her neck all night. And it kind of shows, the research would show that children at that age often can blame themselves for a parent's injury. He blamed his brother, not himself, but so that's another issue again. But I suppose the point is that it shows the need for that child to be given some kind of explanation, education at an age appropriate level to explain what exactly happened to his mum and why it happened. So obviously, so that he's not worrying and it leading to other problems in the family. So I just thought it would be nice just to show a couple of examples there. But I suppose, so going on to the main aims and objectives of the study then. And as I said, I suppose the main aim is to strengthen the family approach to rehabilitation. But I really wanted to look at, I suppose it was always seen that if there was any direct work done with children, it was the social worker that did it. And I wanted to support other staff, I mean, social workers as well, but also other members of the interdisciplinary team to be inclusive of child relatives and to have confidence to be able to work with children directly, or not even just that, but that maybe they could help support family members to work with their children. Because we do get often parents, either the brain injured or the non-injured parent, who would say, oh, my children are fine, they're very young, they don't understand, it's grand. And we kind of wanted to make sure that they realize, you know, it does have an impact and it will have an impact going forward, and we have to consider that and look at that. So I really wanted to raise awareness of it, I suppose, for everybody. So the method, in terms of the methodology that I used, I firstly did a scoping literature review. So I did a literature search of the current research on the impact of acquired brain injury on child relatives and on parenting capacity. And I suppose that I also had made contact with Dr. Audrey Daisley, who's a psychologist in the UK, who's very actively involved in working with child relatives. And she was very good, I suppose, consult to have, and gave some guidance and I suppose tips on other literature that might be useful as well. So she was a really helpful resource. I also did consultation with social workers as expert clinicians, and I'm particularly calling us that because we don't do that enough. And, you know, I suppose I'm talking about looking at family-focused rehab and looking at the patient within the family system, and that's what we do in social work. And I think it's important to kind of, you know, include them. So I talked to social workers about what their view would be and what's needed, and, you know, what we could look at when we're working on developing some kind of intervention for working with children. I also consulted with all the members of the disciplinary team. So I went to each department, their departmental meetings, and met with them and talked to them about the importance of children and involving children, but also asking them what they need to know, what they would like to do, what kind of information would be helpful for them, what format, all of that. So then I drafted a pilot pack. I drafted a pack which was piloted for 6 months in one brain injury ward. And I suppose after that, there was informal feedback, you know, and it was more to do with, rather than the content, the feedback was about the layout and that kind of thing. So then we reworked that, I suppose, and the official launch was in October 2018. And we had Dr. Audrey Daisley, who I spoke about. She came over to launch it as well. And we had a parent who'd had a brain injury who talked about his experience when he'd been an inpatient and going home and the impact on his family. And I think that was just useful to spread the word, I suppose, a little bit, to try and, you know, make it known to everybody in the hospital. And then I suppose after that, then in January 2020, I did a Survey Monkey to try and get some more formal feedback on the pack and if it's been used and how useful it is. So I won't get into this too much, but I just wanted to give you an idea of what the pack is. So I suppose it's divided into a number of sections, and the first section, I suppose, is more theoretical information. And I should say this pack is particularly directed at staff. So it's more rehabilitation staff, and we have given it to teachers as well, sometimes school teachers. It's really useful for them. So it's got theoretical information on the impact of brain injury on children, on parenting capacity for the parent. It also looks at, I suppose, the benefits and why we should include children, and what's the benefit of family-focused rehabilitation, and the benefits of promoting resilience and working with the family. And there's also a section on it on just information on child development stages and the level of understanding of children at each stage. So how they would interpret and understand what it means for the parent to have a brain injury. So that's, I suppose, sections just to give all that kind of general information to staff. Section 2 then is more practical. And it has tips and guidelines on how to work with children and how to answer their questions and how to include them in the rehabilitation process. I've listed as well, there's common questions that are asked by young children and by teenagers and how to answer them. So in, I suppose, an age appropriate way. So for example, we use the example of the brain as being like a command station of a spaceship. And, you know, for the under 12s, that does really work to kind of help them to understand what exactly the function of the brain and just explaining it. So it's quite useful for staff. I suppose they can use those questions, or even sometimes we can give those questions and answers to the parents or the family members, and it can help them when they're talking to their children. There's a resources section then in the pack as well, which I suppose directs the reader to available resources for children. So there's lots of websites and books and games and various things that are useful for children to help them understand ABI. The pack also has, or the resources section also has, some information leaflets, which are basically, I suppose, a summary of the first section with all the theoretical information. So they're just quick handouts that will give you a brief kind of overview, because I know obviously not everybody is going to read a whole book. So just to give leaflets quick and handy, how is a child affected? What are the tips to support them? And why include children? And what are the benefits in the first place? And then we also have signposts for the different child support services that are available in Ireland, because obviously we're talking about working with children and supporting them, help them to feel included. But obviously we have to direct children to more support services if there's a bigger kind of concern. And then we've got some appendix where there's a workbook, which is, I suppose, can be given directly to children, either by the parent or the staff member, whoever wants to do it with them. And it allows the child to talk about their experience, who in their family has the injury, how it's impacted, how it's changed the family member's behavior, how it's impacted on the child and how they feel about it. Just to help, I suppose it helps to signpost us as well, how the child is really feeling and if they are coping. And sometimes children are afraid to say to their parents, to share their worries. So it gives them an outlet that they can do that, and then we can help work with that. There's also a couple of handouts included that can be given to parents. So I suppose that's the first step in making it a more parent friendly pack. So that's also just to help them. So I suppose in terms of feedback, and this was done and we sent it out to the world and hopefully people would use it. And I suppose at the start it was informal feedback we got, and it was very positive, the initial response, and people found it very useful. And I could see as well there was kind of a marked change to social practice. So there's more and more social workers that were engaging in sessions with child relatives. So it was really good informally. But then we wanted to, and actually the other, I suppose, informal feedback that I noticed, and the good outcome was that there was more consideration of parenting tasks when setting rehab goals. So for each patient, the IDT get together to set goals for patients, and it wouldn't always have been considered to look at parenting goals, whereas it does seem to be more now. And I think that pack helped with raising awareness that this patient is a parent, so we need to look at, can they help with homework? Do they have the cognitive ability to help with tasks? Can they get down on the floor, physically play with the child and stand up again, you know, all that kind of thing. So there was a marked change in that. But obviously then we wanted to get more formal feedback from it as well. So we distributed a survey monkey in January 2020 to measure some outcomes. And that was distributed, I suppose, to therapy staff and kind of a number of staff who might have had the reason to use the pack. So we got 15 responses, which is a response rate of about 30%. So it's not a lot, but I think it was quite useful for us. I've included a couple of quotes, which the first one's very long, so I won't get into it, but I suppose the point of the first couple is there was positive feedback that it helped some staff who were going to work with children. So it helped to inform them of how to communicate with the child and how to work with them, and also when talking to families. And I suppose, so that was quite positive, but I think in some ways the last quote there is the most telling, and what I learned most from it is that the person says, I'm unable to comment on the resource pack because I haven't seen it. I didn't know it existed until now. I would be interested in having copies of it, as a lot of patients that I see have children, and a majority of my patients were never inpatients, so wouldn't have had access to it. So that was quite interesting because I suppose it made me realize, okay, you know, I wanted to do research that had an outcome, and it did. It had a pack, something physical and tangible that people could use. But then if nobody's using it or nobody's seeing it or even aware of it, so really the importance of raising awareness, I saw from that. And I suppose we did, act on that then, and we did a few different things. So we put it on the NRH website, so the pack is now available on the website for anyone to see. We sent it out to various agencies and hospitals, also to Acquired Brain Injury Ireland, other agencies like that, to build up awareness. We also sent it to INSWABI, which is the International Network of Social Workers in Acquired Brain Injury. So that's an international organisation, and they put it up on their website as well. And that, you know, got it known in a few other countries as well. And actually recently we got a request. Got the pack translated to Swedish. So there are children in Sweden filling in a little book on what's the story, probably not in a Dublin accent, but so it's good. It's good to see that it's getting out there a little bit. And also actually I had an article published in the Irish Social Worker Journal. This would have been the winter edition in 2019 on the pack and on doing research and on the resource pack itself. So we're kind of getting it out there a little bit. I've just included a couple of slides. I know we're almost out of time. A couple of slides there on just some of the questions we asked in the survey. So one was obviously how relevant is the material to your role? The majority, or 60%, were extremely relevant, with just about under 15 very relevant. And the majority were satisfied with the resource, which is great. So in terms of future plans then, I suppose just the note there on the spinal cord injury, the spinal team here at the NRH are looking at a resource pack for supporting child relatives of adults with a spinal cord injury. So because obviously I dealt only with the brain injury side of it, and we do have patients with spinal cord injury and limb absence. So there's other areas, so it's spreading out, which is great. I'm also working on the parent pack at the moment. So it's looking at modifying this existing resource pack and aiming it at parents who either are the parents with the brain injury or who are the non-injured parent. So that I worked on a draft, myself and another social work colleague, Kira. We had a focus group with some parents, some non-injured parents, to get their feedback back on that pack. So they came up with suggestions, and we've included now some case studies, and just to kind of make it more, I suppose, parent friendly and reader friendly. So that's waiting, it's almost ready to be printed. So that's the next step. And then we're also going to run COVID, I suppose, was a problem with that, but we're planning to run a SIP shop. So, which, as you know, is a support group for children who are siblings of a child with a disability. So we're going to run a kid shop version of that, which would be a support group for children of adults with brain injury. And so hopefully we can do that this year. So there's been a few things that have come and have led from that initial research. So there's more to do. In terms of the challenges then, I suppose, really it's having the time to do the research. As I said, I was very lucky for the initial period. I had a couple of months of no caseload, no other task, only the research, which made the complete difference in getting it done, really. And I suppose the fact that I'm doing the parent pack now, the second pack is taking much longer because I'm trying to do it along with other things. And I suppose it's just much harder when you've got competing demands with social work caseloads and other demands. In terms of getting buy-in for colleagues, I suppose it can be a challenge to get buy-in from colleagues and for them to see, I suppose, the importance of doing research because it can look like it's taking time away from direct patient care. And obviously patients and families have to take priority. But then I suppose that you need, I suppose, to have that research to show that that's also beneficial. And doing research can benefit patients and families as well. It's on the wider level, but it's trying to, I suppose, make that clear and show that it will benefit patients as well and families. In terms of raising awareness, as I said, I suppose I found it difficult at the beginning to raise awareness of the research. I got a lot of interest from people, and everybody was very interested when it was done first. But then I suppose the challenge is to try to encourage people to use it. So to use the pack and not to have it sitting on a shelf. So I think that requires a lot of promotion, and it's you know, just do it and leave it there. You still have to consciously bring it up. That the pack is there and talk about children and keep it live, I suppose. So that can be a challenge, I think for social workers it's particularly challenged because we're not very good, I don't think, at selling ourselves and talking about what we're doing and research. So I think, you know, if we did that a bit more, I think it would help as well to say, look, this is, you know, what we're doing, and, you know, there's research backing this up of why it's important, and there's literature backing up what we're doing. So yeah, so I think that can be challenging, really. So I think that's probably it, because we've 3 minutes left. So thank you very much for listening. I've just put up my email, my NRH one and my UCD email, just if anyone is interested in contacting me afterwards. But I'll stop sharing, put you back to Sarah. Thanks very much.
Thank you so much, Phil. That was absolutely fantastic as well. And obviously a very different presentation. And, you know, for me, it was just so interesting to hear about those drivers from yourselves as the social workers around the need for this, but also I think for your project, probably quite a unique supportive environment in terms of the NRH having that funding stream that you could apply for that helps support you to get this project over the line, which unfortunately we'd love to see a lot more of that, but it isn't as commonplace. And I suppose some of your really frank, honest reflections around what a difference that made to getting the project over the line. And yet even with all of that support and resource and time, you know, you come out with this tangible project or tangible output, but that difficulty still there in terms of that dissemination piece and people really taking it up and that longer term organizational change. So it's fantastic. And for me, like, it was so striking, that kind of attention to the needs of both the child and the parent, and that kind of increasing focus on parenting capacity. So we're getting some nice kind of lovely presentation in the chat, Phil. But I'm wondering, does anyone have any kind of specific questions they have for Phil around her project? I think we've got very shy audience today, or else everyone's hungry. Fiona said she works in the neuro department in Crumlin Hospital, and she'd love to hear more about this. And again, you know, I'm sure a lot of what you talked about has resonated for people. And I suppose what really resonated for me, because it really came up for us in the Family Meetings Project, was that balancing of agendas. And for some reason, as social workers, we do really struggle with that tension between, you know, if we have a research project versus, you know, as you see, our patients and families on the ward, and other professions just seem to be, I don't know, better, but I found different ways of prioritizing that. Whereas I don't know whether it's just, I suppose, our professional value base and our education, where I suppose maybe our allegiances and our priorities always lie with our patients and families, and maybe we need to shift that a little bit in terms of, as you say, you know, research is equally as important and beneficial. It's how we kind of prioritize our time. So yeah, lots of fantastic presentation comments, but anyone else, any other questions? No? Or reflections? Okay. Well, I suppose we know that there's lots more good work continuing, Phil, in terms of, you know, hopefully that pack now being translated for the spinal cord injuries, and then to have that parenting pack as well will be fantastic. So we'll really look forward to hearing more about that, and for the practitioners in the field, hopefully using that in their practice. So thank you so much again, because again, it's so useful for us to get those insights into what you did and how you went about it.
Thank you.
So look, I might ask if everyone could turn on, I know Neve, my colleague, and I know people probably aren't going to do this, but anyone who's comfortable would like to turn on their cameras before we finish up, and Neve may take a screenshot. I'm not sure we're going to get that, but I'm encouraging people to do it. Again, what I would say as well is, look, this is just the first seminar of we hope will be more going into the future. We'd really encourage you to make contact with us, either if you want to present, or indeed if there's maybe a focus around particular type of research, or carrying out research that you'd like us to maybe organise a webinar on. You know, we'd love to do that, you know, whether that's about developing your research question or different types of methodologies. You know, we're really open to suggestion, and really, I suppose the whole idea, well, people can't turn on their cameras. Apologies, I'm asking for something people can't do. So we won't have a screenshot. But I suppose moving forward, you know, we'd really like to try and meet people's needs. So if you have any burning desire for input or a webinar on a particular topic, please let us know, either via Twitter or drop one of us an email, and we'll see what we can do. Because again, we really hope this is just the first of many moving forward. So I suppose we're at lunchtime. We've had a great session. We've had 2 fantastic presentations. So again, I'd just like to take this opportunity to thank the co-organisers, Kerry, Yvonne and Neve, and also for the admin support staff in Trinity College Dublin for assisting with the Zoom today. That's been invaluable. So other than that, thank you so much for attending. Safe home virtually, and we look forward to seeing lots of you hopefully at our next seminar. So goodbye and thank you very much.
Thanks, Sarah. Bye.
Thank you. Bye.